Most of you are aware about this CPT, convalescent plasma therapy, and there was a lot of excitement in the beginning before this RCTs, randomized control trial, including Placid Trial. The results, they were out, and I mean, you must have read in the newspaper also. The perception in the public, it was, so high that they were thinking this was, some sort of, panacea for COVID-19 disease, where all the therapy, like for example, remdesivir or tocilizumab, they were not working, and they were trying it as a last resort. So with this background, now even WHO trial, it has also mentioned that remdesivir is only effective in the, initial stage of the disease. So we have no approved, therapy for COVID-19, including any antiviral drugs or convalescent plasma therapy. Having said that, there are indications, there are, case reports also, there are some observational studies which have indicated that convalescent plasma therapy may be useful, and it should be tried, of course, in the, beginning of the disease. This convalescent plasma, or we call it, immune plasma, is one that is collected from, patients of COVID-19 who have recovered completely, and they have developed neutralizing antibodies against SARS-CoV-2. And historically, it has been used earlier in many viral infections, almost, in 1918 in Spanish flu, in SARS, in Ebola viruses, but the results, they have been mixed. In some cases they have shown some improvement, and in many cases they have not shown any, benefit in convalescent plasma therapy. As of now, in COVID-19 disease, the main indication is off-label use or on compassionate ground, and this is useful for those patients who are in early stage of the disease, having, mild to moderate category of COVID-19, and who are not improving, even despite giving oxygen, and the oxygen requirement is increasing, and this is for off-label use, and the patients are also on steroid. This is not working. So in certain cases, in select category of patients, it may be tried. So earlier it was being used as part of clinical trial by ICMR in India especially, but now the things have changed, and now even ICMR has come up, recent guidelines. This is advisory which has come out, and I will be discussing in the end of my, lecture. What is the mode of action? It normally, the antibody, which is neutralizing in nature, it causes, blockade of virus. It doesn't allow to, virus to enter inside the cell, and which takes the help of, ACE2 receptors inside the body. And most of the, antibodies which are, they are what we call in neutralizing. Actually, they must, neutralize the antibodies. The virus. They have to neutralize the virus, and there are many mechanisms they can directly neutralize it, or by antibody-mediated pathways such as complement fixation, or ADCC, or by phagocytosis. So these are the different, mechanism of, its action. There are some non-neutralizing antibodies also, and they may also contribute to enhanced recovery. So most time, this immune plasma, convalescent plasma, they are mainly IgG in nature, but then IgM antibodies are also forming. Ig antibodies are also equally important. So it has been seen in many patients in China that the formation of, say, IgG antibodies or IgM antibodies is totally, it's very haphazard. In some patients, they'll have first IgG antibody formation. Normally presume that IgG antibodies, they will be formed after 15 days. But in many cases, IgG antibodies may be picked up earlier than IgM antibodies, which are supposed to be the first antibody. Or there may be, simultaneously, many patients, they can form IgG and IgM antibodies. So at present, in our center, we are only looking for IgG antibodies against spike protein, that is S1 of RBD region, receptor binding domain. That is the most important for us. And having said that, like, we are not checking for, IgM antibodies, because for convalescent plasma, our main focus is IgG antibodies, which we call it immune antibodies. So it has been seen in most of the studies that such patients who have completely recovered, they form antibodies, high titer antibodies, IgG, after 14 days, that is after 2 weeks of symptoms resolution. And in 1/3 of the cases, they may not form any antibody, neutralizing antibodies following infection. So we can see that this plasma, apart from any plasma proteins like albumin, cytokines, protein C and S, it also contains antibodies, immune antibodies. And again, the shelf life is almost 1 year for this plasma, which can be stored at say -30 degree or -18 degree Celsius temperature. It may be collected by plasmapheresis. Most of the centers now they're going for plasmapheresis, and it can also be collected by whole blood donation also. But again, this is slightly controversial thing. Not many centers they are going for whole blood donation, but again it can be done. So neutralizing antibodies, right now we don't have mini kits which are commercially available. Not many centers are doing neutralizing antibodies, because for that we need biosafety level 3, and because it's a live virus, and culture, we don't have that facility. So there are one company in my knowledge, things GenScript, which has come out with the neutralizing antibodies commercially. Otherwise, this is not really important at the level of say blood bank or transfusion medicine department, wherein whatever approved technology like chemiluminescence or ELISA, if you are doing, that is equally good. And the recent guidelines from ICMR, they have suggested that if the IgG antibodies, if you are doing by say chemiluminescence, for example, from say about technology, then 13 AU may be taken as reference, and or otherwise, if ELISA, then the titer of antibody should be 640. Or if you're doing by say mini neutralization test, or pseudotype neutralization test, then the neutralizing antibody titer should be 1:80. Or if somebody is say using antibody CLIA based on ortho platform, then if it is called say Vitros, then we are looking for signal to cutoff ratio. If it is more than or equal to 12 IgG signal to cutoff ratio, we presume that it's a high titer antibodies. So what happens? These antibodies, FDA, US FDA, they say it is the titer should be approximately 1:160, and even 1:80 may be acceptable, which is corresponding with the ICMR titer for neutralizing antibodies. So these neutralizing antibodies, they cause antibody mediated viral elimination. And why? I mean, this is important because it has been seen even in the ICMR studies and in many other studies worldwide that early conversion to viral RNA negativity in patients, it has been seen, because those patients who received plasma, conventional plasma, they came negative, they became RT-PCR negative quite early as compared to the control arm. So the possibility is that the viral load, it correlates significantly with the pro-inflammatory cytokines, namely interferon alpha, interferon gamma, and TNF. And if there is a lesser viral load, it will translate into less tissue damage and inflammation. So there's a very good study in the Science Journal, and they have mentioned that there is a flawed interferon response which is for severe illness. And they mentioned that because interferon, which is antiviral nature, interferon is produced by many patients, and it can decrease the viral load. So if there is early interferon response, there is rapid viral clearance, and then the patient of COVID, he will have a mild disease. Where if there's a delayed interferon response, the virus is not cleared, they persist, they cause more inflammation, and this can cause more severe disease. So there is, as you are aware, that there is a immunological misfiring in most of the patients, and some of these patients, they also develop neutralizing antibodies against interferon. So these IgG anti-interferon antibodies, which are present in 10% of the patients, they are quite dangerous. So if you're collecting, say, convalescent plasma from such type of donors who have already formed interferon neutralizing antibodies, then you are in trouble, because these interferon neutralizing antibodies, when they will be transfused to the COVID patient, they can cause depletion of the interferon of that particular recipient, and instead of causing benefit, they will cause issues. They will cause complications in such patients. So you have to be very careful that not all serious patients of COVID, they are a very, very good candidate for plasma collection. They cannot donate plasma, at least 10% of very serious patients. So coming back to the dose of this convalescent plasma therapy, most of the trial they have recommended 200 to 500 ml in single or double doses. ICMR, they mentioned that 2 aliquots of ABO compatible plasma, 200 ml in say 24 hours apart, they may be used. And of course, everybody knows that AB plasma is the universal donor. And recent guidelines by DGHS, Government of India, dated 1st July, they mentioned that 200 ml single dose given slowly over less than 2 hours, it may be used for most of the patients now. How we monitor the response to convalescent plasma therapy? Response in published trials, it has been measured clinically, that is by PF ratio, or radiologically by improvement in X-ray or CT scan, and surrogate endpoints, they include anti-COVID antibodies titer, or the absolute lymphocyte count rises in the patient if there is some benefit, or there is some drop in the SARS-CoV viral load, or improvement in the IL-6 level. So these are the few monitoring endpoints. And then we have contraindications to plasma therapy. As such, we don't have any significant, other than like if there's some allergy to plasma proteins or selective IgA deficiency, or some patient or recipient has already received immunoglobulins in the last 1 month. If patient is on, say, in shock, or there is severe thrombosis, multiple organ failure, as well as pregnancy or breastfeeding, they also serve as contraindications. Side effects, they're not much, and there was some possibility of antibody dependent enhancement that was normally seen in, say, in dengue patients also, but it has not been reported so far in convalescent plasma therapy recipients. It may aggravate, however, the thrombotic profile which is seen in many patients. And also at our center also, we are monitoring our patients by thromboelastography and by other coagulation parameters, and we have observed that many times many patients, they were on anticoagulant therapy like LMWS or on heparin, but despite that they presented with hypercoagulable profile. So their doses of anticoagulant therapy, they were tailored according to the result of their tech tracing. So and such patients, they can also present with trally or allergy also. This is one study which was published in the Journal of Clinical Investigation. This was done in the USA, and they have mentioned that this transfusion of convalescent plasma is safe in hospitalized patients with COVID-19, and the incidence of all serious adverse events in their population of 5,000 cohorts patients, it was less than 1%. It was not very high, they said, and most of the cases, I mean, including the mortality, transfusion associated circulatory overload, that is TACO, and TRALI, they were allergic reactions. They were quite, they were almost not very significant, and only 2 of the 36 serious adverse events, they were related, definitely related to the convalescent plasma therapy. So what are the steps which are involved in convalescent plasma therapy? Most of the centers in UP, at least, I think 15 centers, they are engaged in convalescent plasma therapy. What we have to, believe, we have to, observe that there is no, rat race. We don't have to justify, every plasma collection or plasma transfusion. We have to go by the published literature, what the, randomized control trials say, and accordingly, you will see that at our center also, the first step is like it's very difficult to recruit, and because there is a very less voluntary donation, and at our center now we have stopped asking for replacement. So the stock, remains relatively low most of the time. And once we have like recruited the donors, the recovered patients, we have to assess them whether they will be taken for plasmapheresis, or maybe if they are eligible, they can donate whole blood donation also. We have to do IgG antibody detection or titration as per the facilities available at your center, and then TTI markers, including nucleic acid testing, blood grouping, and other investigations which are required for whole blood donation. Uh, if if there is a facility, you can also do the thrombelastography for detection of hypercoagulable profile, and then the units are issued depending upon the requisition and the proforma. And this proforma, what we have made at SGPGI, that I will be sharing with you, and this very important. And so this is like the blood is separated by plasmapheresis, and then the plasma is tested for anti-COVID antibodies by ELISA or by CLIA. And if you have micro neutralization assay, it can be done. And it has been seen that the convalescent plasma, this antibody titer is high if the patients, the record patients, are males, and if they were admitted patients, as compared to the patients who are in, say, home isolation. Patients who are hospitalized, they are having higher antibody titer. So, and the latest guidelines, they also say that after 14 days of symptoms resolution, any COVID patient can donate plasma. And the testing is for COVID, that is for RT-PCR, is not necessary now. And however, there are a few issues which are involved. As I mentioned, there is very less voluntary donation. Majority donors are asymptomatic, or they had, very mild disease. Cost of the kits for antibody detection in COVID patients, if you're, trying to look for antibodies in the patients and in the donors, of course, you have to do that. Then it is very, exorbitant, and there are no uniform guidelines. Even the guidelines by ICMR, they are changing very fast. And what was, pertinent, what was okay, say in few months back, now they have all been, revised in the light of, latest guidelines and knowledge. And follow-up details by clinicians, they are not being shared, on time. So this one study, that is Placid Trial, it changed the total outlook. And the key findings of this trial, that is convalescent plasma in management of moderate COVID-19 in adults in India. It was an open label phase 2 multi-center randomized controlled trial. And they mentioned that there is the progression to severe disease or mortality at 28 days. It was there, and it didn't stop. By using convalescent plasma therapy, there's no change in the mortality or to progression to severe disease. Mortality was recorded in 15% in the intervention arm, and in the 14% in the control arm. Control arm means those who were only on the standard therapy. And in the intervention arm, these patients, they were having standard therapy and apart from convalescent plasma therapy. However, what they noted, that a higher proportion of patients that received convalescent plasma, they showed resolution of shortness of breath and fatigue at day 7. And many of the such patients, they became RT-PCR negative at an earlier, quite early. However, this study was criticized, being open label in nature, and the antibodies, they were not measured before transfusion. And the plasma, it had low titers of antibodies, because most of the donors, they were only having mild diseases. So, which might have affected the outcome. So these are the various, studies. There are namely 5 randomized control trials, which are considered as the gold standards in any, trial. And I have not included the observational studies, case studies, and the latest one is which came out, this plasma. This came out published in New England Journal of Medicine in November 2020, and this was a randomized control trial in severe pneumonia patients. It was done in Argentina, and this primary endpoint of this study was clinical status 30 days after intervention. However, the results obtained they mentioned that there's no significant differences they were observed in clinical status or overall mortality between the control and between the intervention arm. This study, the Placid studies, we have already covered, and it didn't show any benefit also other than small changes, clinical improvement. Then there's a study which was done in Spain, and this study, the important thing is that they found out that approximately 50% of their COVID patients, they had preformed IgG antibodies. And however, they mentioned that no patients they progressed to mechanical ventilation or death among 38 patients receiving convalescent plasma versus 14% in control. And but this study was also aborted early, and similarly one study in Netherlands and one in China, both they had to be terminated early because they could not enroll sufficient patients, because China, it contained the disease quite early, so there were no this thing patients who were being enrolled. And in the Netherlands study, what they found that approximately their 80% approximately patients, they had anti-SARS-CoV antibodies at the time of enrollment. So they just terminated this study. And so what we say that now this RCT, they don't invoke much confidence in the use of convalescent plasma therapy. At our center also, we have been very selective, and we are not collecting plasma from those patients who are having mild symptoms or they are not having any fever, so they are being rejected. And we have so far collected 72 plasma donation. That is data for I think 5 or 6 days back only. And our 76% they had fever. These are our donors. And 20% of donors, they had history of hospitalization. The rest were in home isolation. However, our mean IgG signal to cutoff ratio is in the donor is 14.63. That is more than 12%. 12. So it is, we can consider as a high titer antibodies. So if this is just a raw data, we have not analyzed it completely, but what can be seen from this slide that recovery is only 55% in 116 our patients which are admitted in Rajdhani COVID hospital at SGPGI. So the expiry, the mortality is 45, and discharge after recovery is 50, and they still admitted are 21. So recovery is 55% at our center. So this study we did in September 2020, and it was just a pilot study. We wanted to know what is the level of antibodies in our admitted patients. So here we are talking about the patients of COVID who are admitted, and we're trying to look for IgG antibodies against spike protein of the virus. What we found that those patients who had history of 7 days, and there were patients which we divided who were symptomatic, say between 7 to 14 days, and there were patients who were admitted and who were having symptoms, say more than 14 days. So we had in the first category we had 8 patients, the second we have 9 patients, and then we have 8 patients. We found that 12%, if we talk about in terms of percentage, only one patient had IgG antibodies, and here 7 patients out of 9 patients they had antibodies, and beyond 14 days, if there was symptomatology, all the patient, that is 100 patients, they have developed antibodies. And I can share with you that in 2 or 3 patients, they were having IgG antibodies SC ratio of 30, whereas the plasma what we have collected, say it was showing say value of 15. So it doesn't make any sense to transfuse in outside convalescent plasma having say titer of 15 and transfusing to a patient who has already formed IgG antibodies titer of 30. So you have to see that those patients who have already formed autologous IgG antibodies, there is no point in giving plasma. So we decided that based on this study, we decided in September only that we will be transfusing plasma in our patients who are who have symptoms in less than say 7 days of this thing disease, or in rare cases, because where the antibody titer was very small, it was not detectable. Then only we would transfuse in those patients who were having symptoms beyond 7 days. Initially, we made it 10, but after discussion with the clinicians, we raised to 14 days. However, we mentioned clearly that therapy will not be effective beyond 7 days, and that was we said in September. You must be aware, all the transfer medicine persons, and this was from the government of India, DGHS.
आज कितने की ड्यूटी है ट्रू नेट में ना वहाँ कौन
this directive said, this directive came in July 1st, and they mentioned that this plasma can be used as a off-label, and the antibody titer should be more than 1/640, that is IgG antibody titer, and the patient should be monitored. And they mentioned that dose is single dose given slowly over not less than 2 hours. So this was all it came from the Government of India directive. So as I said, that we made a pro forma in September only, and this was circulated to our patients, the clinicians who are working in ICU, and we mentioned that these are the information which we required before we issued plasma. What was the category of the patients, whether it's mild, moderate, severe, date of onset of symptoms less than 7 days, 7 to 14, and then more than 14 days. And we also mentioned if there is COVID IgG, antibodies, if done in the patient, so what was the ratio, SC ratio, what is it means, what is the titer of antibodies in the patient, TEG heparinase profile if done, whether the patient is showing hypocoagulable profile or normocoagulable or hypercoagulable profile, and then the status after transfusion. And we mentioned that this is highlighted here, that convalescent plasma therapy may be indicated if moderate COVID disease and if the symptomatology is less than 7 days, IgG antibodies, they are not present before transfusion or only mild titer present, and moderate to severe COVID disease with renal or hepatic impairment when remdesivir cannot be given. So this we mentioned. And the CPT is unlikely to useful if symptomatology is more than 14 days, if patient is on ventilator. And you will see that on 17th November 2020, ICMR gave a decision matrix, and they mentioned in their advisory, this is not very clear, but that's why I have this is shown here. What they mentioned in their advisory dated 17th November, they mentioned that indiscriminate use of convalescent plasma therapy is not advisable, and they said that convalescent plasma having low concentration of specific antibodies may be less beneficial for treating patients as compared to plasma with high titer antibodies. This they said that the presence of antibody against COVID-19 in a patient, in a potential recipient, makes transfusing convalescent plasma a futile intervention. So it means that if the patient is having, he has already formed COVID antibodies, there is no point giving convalescent plasma therapy. So the potential recipient, as per ICMR recent advisory, these are the indications for convalescent plasma. That is, the patient should be in the early stage of the disease, up to 7 days from the onset of symptoms, but not later than 10 days. And there should be no IgG antibodies by appropriate test, and the patient should have given. So this therapy is as good as your, plasma collection. Like if you are very clear about your donor selection and patient selection, then it may be useful. As regard to donor selection, if we collect because most of our donations, they are from males only. And if they have, symptoms like high fever, and then we presume that antibodies level will be, high on the higher side. And in the patient selection, we have to see that the patients, they are in early stage of the disease, and within 7 days of symptomatology, I think this therapy may be effective, and there should not be any IgG, COVID antibody. And if possible, if you can monitor them for thromboelastography for any, this thing, incidence of hypercoagulation or thrombosis in such patients, because such patients, they are already having a thrombotic profile. And if you're giving them, say, 2 doses of convalescent plasma, we can make them more, thrombotic. So with these, I end my talk, and I urge all of you, the clinicians or the transfusion medicine specialists out there, that we have to be very judicious in giving convalescent plasma therapy. And in excitement, because what we are trying to, at times, uh, what we do is that we are collecting plasma from such donors who are not having, good high titer antibodies, and just we are transfusing to our patients without applying, proper selection criteria. And so we have to be very careful, even for off-label use of conventional plasma therapy. Thank you so much.